Hi, everyone. My name is Stephanie Doback, and I'm going to be talking about enteral nutrition access. So enteral nutrition, or commonly known as tube feeding, is indicated when oral intake is inadequate, unsafe, or not possible. So for example, if the patient has dysphagia, which means swallowing difficulty after a stroke, or if they have head and neck cancer and we need to bypass that area and go straight to the stomach to feed them. They have severe gastroparesis in the stomach, just having delayed emptying, and we need to go through and go straight to the intestines to feed them. Or commonly in the ICU, we have patients that have severe respiratory failure and are on mechanical ventilation. They have an endotracheal tube in and they're not able to eat. That is a great use for enteral nutrition. But it does require that the person has a functional GI tract, that they have sufficient GI length and absorptive capacity to absorb the nutrition, and that they are hemodynamically stable. When we are talking about different enteral nutrition access and what might be best for our patients, there are some considerations as to which tube we might place, if it's going to be a nasogastric tube or a surgical gastrostomy or a gastrojejunostomy tube. And some of those factors are disease state, the patient's anatomy, GI function. What kind of GI function do we have? Do we have any sort of delayed or impairments? The risk for aspiration, the anticipated duration of the therapy, and the expertise needed for enteral access placement. So do we have those resources at our facility? In terms of duration of therapy, we usually divide those into short-term enteral nutrition access and long-term. And short-term is going to be, we need that enteral nutrition for a maximum of 4 to 6 weeks. So in those cases, we'll typically use a naso or oral gastric tube, or naso or oral small bowel tube, or post-pyloric tube is what they are sometimes called. And the reason for that is that, especially if we have a tube going through the nasal cavity, if it's going past the 4 to 6 week mark, we might have some nasal cavity breakdown or sinusitis. But these tubes are going to be entered through the nose or the mouth. In the tip of the tube, it's going to either end in the stomach, which is the gastric part, or the small bowel, so the duodenum or jejunum. Now, we usually stick with the nasogastric or nasoenteric tube, but sometimes we place them orally. This is usually reserved for in the ICU setting when they are on mechanical ventilation. They already have an endotracheal tube in their mouth, so we just go ahead and put through some GI access in their mouth as well. Or if they have facial trauma and you can't use the nasal cavity, then we'll use the oral route. Most patients can tolerate a tube ending in the stomach and feeding into the stomach, even in the ICU. But sometimes we're going to need that small bowel access, typically if the patient has delayed gastric emptying or they're at high risk for aspiration. But note that getting that tip of the tube into the small bowel is a little bit trickier. So the placement can cause a delay in starting the enteral nutrition as we try to find the correct people or the correct resources to be able to get that tip further down in the GI tract. In regards to long-term access, again, this is for greater than 6 weeks that we're anticipating needing that tube feeding. This is going to be your gastrostomy tube, your jejunostomy tube, gastrojejunostomy, or your low profile, sometimes referred to as a button tube. Starting off with gastrostomy tube. So these are going to be placed directly through the abdominal wall into the stomach. And depending on how it's placed is what we're going to call the tube. So most common is a PEG tube, which stands for percutaneous endoscopic gastrostomy. We also have RIG tubes, which is radiologically inserted gastrostomy. Or you might just have a surgically placed gastrostomy, either an open gastrostomy tube or a laparoscopic G tube. This is what they look like. They are secured on the outside with a bumper. This portion goes through the skin, and this is what the inside looks like. It's either a silicone or rubber bumper, or it could be a balloon. They are 12 to 18 inches in length, and the diameter, which is called the bore size, how big the tube is internally, is between 12 and 28 French. On the top, you'll see that there are what we call ports. This one has 3 ports. One is for a feed, it says feed on there, medication, and then the white ones are always for the balloon, and that's for the ones that end with the balloon. If the tube becomes dislodged, this is for any sort of long-term access tube, The patient needs to go directly to either the emergency department or an outpatient clinic within a couple hours, just because if the hole remains open, the stoma within their skin, they don't have to redo the surgery. They can just take one of these tubes that has the balloon deflated, put it in the tube, and then inflate the balloon. And it takes 5 minutes. Unfortunately, if they wait too long, the hole will close up and they'll have to redo the surgery again. For jejunostomy tube, again, this is for long-term use, anticipated use of greater than 6 weeks. It's placed through the abdominal wall into the jejunum. And again, depending on how it's placed is how we're going to refer to the tube. So we have the PEG tube, percutaneous endoscopic jejunostomy, the RIJ, the radiologically inserted jejunostomy, and then our surgically placed J tube, which is called open or laparoscopic. Again, it's going to be secured on the outside by the outer bumper and have an inner bumper or balloon. The lengths are in centimeters, and they're a little bit shorter than the G tubes. And we have 15, 22, 30, or 45 centimeter lengths. The bore sizes, J tubes are smaller. So we have 14, 16, 18 French tubes usually. That means they're more likely to get clogged. So we had to have great care around flushing to make sure that we're not getting clogs in these tubes. They usually have 1 to 2 ports, one for the feeds, medications, and then if it has a balloon, it'd have a second port. And then because the jejunum is not like the stomach, where the stomach can get a large amount of volume at one time, it can expand. The J tubes often need a pump to deliver the feeds and the water. Maximum rate is about 125 to 150 milliliters per hour, but it's really patient dependent. They can either tolerate more or less. But when the pump is not available, say as during a shortage or there's not insurance coverage for the pump, then you can do it via gravity bag. But know that it's probably going to take about 2 hours to deliver 1 8-ounce or 250 milliliter container of feeds. And again, if it becomes dislodged, go directly to the emergency department. All right, next is our gastrojejunostomy tube or GJ tube. So again, this tube is placed through the abdominal wall, and part of it ends in the stomach, the gastric portion, and part of it ends in the jejunum. Generally, these tubes are indicated if we need to feed into the jejunum, but we want to use the gastric portion to either ventilate or decompress the stomach and give meds there too. So thinking about severe gastroparesis, where they could tolerate some sort of medications in small amounts through their stomach portion, but for the majority of feeds, they're going to need through the jejunum. So again, this is going to be secured by an outer bumper and an inner bumper or balloon. The lengths are typical to a typical J tube. So the 15, 22, 30, 45 centimeters in length, and again, the smaller bore sizes. So I have 2 examples of tubes here. I say if you anticipate the patient's going to need a GJ tube, you're going to want to do one that's already connected all in one. So you'll see this has the 3 ports. It says jejunum, gastric, and then this is the balloon portion, the white portion. And so you go down here, this is the external bumper that's going to be on the patient's skin. This is going to be going through their skin, and this is going to be holding it inside their stomach. So this tube specifically has holes right here. So this is going to either ventilate the stomach or put medications to the stomach. And that portion stops there. But then the jejunal portion of the port up here, it goes all the way to the bottom, and that's where you can put the feeds. So this portion is going to go all the way to the jejunum while this portion stays in the stomach. We also have another tube. So say the patient starts off with a G tube, and then they decide, oh, they're not really tolerating it well, but we don't want to do like a separate surgery for a J tube. This is an option as well. So this started off as a gastrostomy tube. They cut off the top, they fed through this little tube, and this goes into the jejunum. I will say this one is not ideal. As you can see, it's smaller, it's flimsier. A lot of times these will kick back from the jejunum and end up ending in the stomach. So it's not super ideal. So if you know from the get-go that your patient might need a GJ tube, go with the first option. Again, because the portion of the tube that we're going to feed ends in the jejunostomy, we're going to probably use the pump and with a maximum rate of around 125, 150 milliliters per hour. And our last tube is the low profile or button tube. So these can either be G tubes or J tubes. Again, they're going to go through the abdominal wall, and I have my little baby here, and this is what it looks like. Okay, so you'll see that it just has this button or disc sitting on the outside of the skin, and the inside has the balloon. The bore sizes really vary from 12 to 24 French. And then you're going to need an extension set for these feeds. So when it's not in use, the person's going around with this capped, but then when they go to use it for either feeds or medications, you have these separate extensions that lock in, and then you have the separate ports, and you can feed that way. And then you just remove that when it's not needed, and you rinse it out, can reuse it, and go ahead and close that up. This is ideal for pediatrics or patients that are cognitively impaired, prone to pulling at tubes, because this is flat and out of the way. And they do need more frequent replacements. Actually, all the balloon tubes do, because the balloon on the inside tends to degrade over time. It can deflate, so we recommend changing these every 3 to 6 months. If you have one of the regular G tubes that ends with like the silicone ending or the rubber ending, those don't need to be replaced as often. Those can go 1 to 3 years. So that's it for tubes. Really excited and passionate about this. So if you have any questions, please drop them below. Thanks so much.